Okay, good morning, everyone. Sorry, I'm like in the middle of losing my voice. I don't know what's going on, but today I will be talking about the approach to the non-traumatic red eye. It's a very much like 15,000-foot view of just what to think about if you encounter a patient who comes in with red eye, not endorsing any trauma, no injuries. I want to say thank you to the Small Talks team as well. Okay. So this was random. When I was putting my presentation together, I just thought about this movie. What happened was that I Googled red eye and then this came up. I don't know if anyone's seen this, but it's a pretty traumatic movie, which is not going to be the topic of my talk today. Okay, so you're on shift. You see eye complaint in the triage note on the board. You go see the patient and he looks like this. What questions are you asking this patient when obtaining a history? I can't see the chat right now, so go ahead and unmute yourself. And
Any trauma?
no trauma. Well, that's a good question, but no trauma.
Does it hurt?
What was that?
Does it hurt? Is there any pain?
Good. Anything else?
How's your vision?
Awesome. You guys are on the right track. So obtaining a detailed history of an eye complaint is just as important as any other presentation in the ED. The differential diagnosis of red eye can be narrowed down rapidly with simple baseline questions like you guys stated. How's your vision? Do you have any pain? Any history of any injuries? So really be targeted with your questioning. You want to make sure that you ask about exposures to chemicals or infectious agents, what their baseline visual acuity is. They may not know. Ask about associated symptoms like headache or photophobia, systemic symptoms like cough, congestion, runny nose. Ask about any history of any known ophthalmologic problems. Sometimes patients might not disclose this, like any other complaint. When we usually ask them, do you have any past medical history? And they say no, and you go to their chart and it's a running list. So ask about those things. Ask about baseline medical problems, current medications that they're taking, duration and laterality of symptoms. Is it unilateral versus bilateral, which you should also see on your visual exam. Character and location of the pain, for example, is it more upfront? Is it like a scratchy, gritty, sand in the eye feeling? This types of characterization usually relates to anterior structures as like the lids, the conjunctiva, or cornea and foreign bodies. Ask if there's like a deep boring behind the eye, like toothache that's associated with the eye pain. This is usually related to posterior structures. And then photophobia usually relates to uveal tract of pathology, such as the iris or ciliary body. Okay, back to the audience. So you pick up another patient and somehow it's another eye complaint. What are you thinking about in this patient?
Why is it anisocoria? That's weird.
Great, Tobias. Okay. Any differentials?
Glaucoma.
I didn't hear that.
Glaucoma.
Okay, good. Exactly. So signs and symptoms related to acute angle closure glaucoma are typically unilateral, headaches, blurred vision, halos. Patient might also present with nausea and vomiting. On your physical exam, you might see a red eye. Obviously, you'll see a red eye. It might be firm to touch, minimally reactive mid-dilated pupil with markedly elevated IOP on your tonometry exam. And then one thing I did learn was you can also do something called the positive oblique or oblique flashlight test, and it's positive in these patients because usually you'll use a flashlight and you'll take a look at the eye from the temporal view, and if they have nasal iris shadowing, that's indication that there's increased depth of the anterior chamber, and that's usually positive in people who come in with acute angle closure glaucoma. This is another presentation of a person who's coming in with red eye. Any ideas what this could be? This one is a little bit more difficult. So this is iritis, also known as anterior uveitis, and it's the inflammation of the middle layer of the eye directly beneath the sclera. One cardinal sign that is usually seen in iritis is ciliary flush. So if you take a look just right outside of the iris, there's like a red kind of ring around the entire iris. And this is usually seen in anterior uveitis. It's also known as a periumbral injection. So in this, you'll usually see the pupil is usually constricted and minimally reactive, and then you'll have a concentric light reflex that exacerbates pain on exam. This is more obvious, but you see the patient, they've come in with red eye, you decide to do a fluorescein stain, and you see this. What are we thinking?
Like a herpetic
Herpes.
fungal infection.
Yeah, so like more generally, just like a keratitis. And this can be due to direct abrasion or infection. This specifically is a viral keratitis, and it's commonly caused by HSV, but can also be caused by EBV, zoster viruses, and CMV. So keep those other viruses in mind. And also think about this in your immunocompromised patients. Okay, so you are doing other elements of your exam while you're seeing these patients who are coming in with red eye complaints. Somehow you find the time to do a fundoscopy exam, and you see what's on the right. What are we thinking?
Anus, sinus, thrombosis.
Okay. So there's a patient, they have an edematous optic disc. They're also
Cupping?
What was that?
Is that cupping?
This is not specifically cupping, but the patient is also having some blurred vision. This patient came in with optic neuritis, but on your fundoscopy exam, you're going to see an edematous optic disc, and they're also going to be complaining of usually monocular, like vision loss or blurred vision. Some of the symptoms might be like a deep boring pain behind the eye, pain with like extraocular movements. They might have a history, they'll have a history of MS most likely. And on your physical exam, you're going to see pale edematous optic disc on fundoscopy and probably an afferent pupillary defect. This one might be a little bit harder because we don't do fundoscopy exams very often. So it might be a little bit more difficult for us to really tell the difference between like edematous disc versus cupping, but it's something to consider doing in the ED. So you have a patient who also comes in complaining of painless monocular vision loss. All the way to the left is like a normal fundoscopy exam. In the middle and to the left and to the right, excuse me, are abnormal exams. So what do we think is going on in the middle photo? They're coming in with painless red eye with acute vision loss.
CRAO.
Good, exactly. Also known as maybe like eye stroke. You'll see a cherry red spot on your fundoscopy exam. They'll be complaining of profound sudden vision loss that is painless and monocular. Fundoscopy will show retinal pallor as well as the cherry red spot. And then they'll have poor visual acuity, likely on exam. And this warrants an emergent opto and neurology consult. To the left is CRVO. This patient may present complaining of blurred to sudden vision loss. On fundoscopy, you'll see optic disc edema and diffuse retinal hemorrhages, also known as like the blood and thunder sign. Risk factors for this include hypercoagulable states and glaucoma. This is a way to kind of differentiate your diagnoses for this one would be a fundoscopy. That would be very helpful, and also their history. And then think of this CRVO as more of like an eye DVT because it occurs in the retinal vein. Okay, so in addition to getting a good history, you also want to do a great eye exam. And I know sometimes in the ED, what we can do is limited to time and resources, but you want to be thinking about all of these things when you're doing your eye exam. Their visual acuity, also known as the sixth vital sign, is really important. Um, it's good to have a stepwise examination approach. So you want to incorporate all of these parts in your exam. Obviously, the pupillary exam, checking extraocular movements if there's pain with extraocular movements, your visual field by confrontation. I would suggest YouTubing this just to remind yourself of how to actually do this properly. Obviously, getting an IOP once you've once you've gone to get your tonometer from the CCT, you obviously want to do an IOP. And anyone who's coming in with red eye, or if it's like hard, you want to be considering acute angle closure glaucoma. Doing a good external exam is really important. Taking a good look at the eyelids, the eyelashes. If there's any chalazions or hordeolums around the eye, you want to be thinking about those things. A slit lamp exam. So I don't know how many of you have actually done this. I have yet to do this, but this should be part of your eye exam when you're seeing a patient who's coming in with any type of eye complaint. And then finally, a fundoscopy, taking a look at the eye, behind the eye, seeing if you can visualize the optic disc, if there's any edema, blood and thunder sign versus a cherry red spot. This will help you narrow your differentials. And also it will give more information when they come to see your patient. So some take-home points: always have a broad differential on evaluation of the red eye. Suspect glaucoma in any patient with an acute change in vision and get an intraocular pressure measurement as soon as you can. The importance of a complete exam cannot be understated. These include the visual acuity test, pupillary exam, intraocular pressure, extraocular movements, fundoscopy, slit lamp. And then consider autoimmune disease in patients with systemic complaints or unclear etiology when diagnosing these eye pathologies. And these are my references.